afternoon, everyone, or good morning if you're on the West Coast. I am Kat Anderson, Director of the Roundtable on the Promotion of Health Equity under the Board on Population Health and Public Health Practice at the National Academies of Sciences, Engineering, and Medicine. Next slide, please. I want to welcome you all to today's webinar called Doing It Right, Contact Tracing and Health Equity. This session today is organized as a series of conversations with our three panelists. The Roundtable on the Promotion of Health Equity is developing a series of short webinars to focus on critical issues relating to COVID and health equity. This webinar is the second of this series of webinars. And this webinar is being recorded, and the archived video will be available at the link above or on the slide. Additionally, a short publication summarizing the webinar will be available in the future on the Roundtable's website. This event builds upon an earlier webinar hosted by the Roundtable, Pursuing Data on COVID-19, the Health Inequity Multiplier. You can see this webinar on the Roundtable's website. The link is the bottom link on the slide. Let's see. States and communities continue to report that the pandemic is disproportionately affecting people of color. As infection rates rise across the country, one critical tool is contact tracing. Next slide. I now want to introduce the moderator of this webinar, Dr. Winston Wong, who is the Medical Director of Community Benefit and Director of Disparities Improvement and Quality initiatives at the Permanente Federation, Kaiser Permanente. In this role, he is responsible for developing and cultivating partnerships with communities and agencies in advancing population management and evidence-based medicine, with a particular emphasis on safety net providers and the elimination of health disparities. His background includes leadership roles in community health, government, health plan delivery, and Dr. Wong serves as the chair of the Roundtable on the Promotion of Health Equity. So I am going to turn now to Dr. Wong, who will provide some opening remarks. Winston?
Well, thank you, Kat. And I want to thank you, Kat, specifically for all the hours of work she has put into this particular webinar, as well as the fact that she is the foundation of our work at the Roundtable for Health Equity. So thank you, Kat, and all the staff at NASA to make this webinar possible. I also want to acknowledge that, of course, every morning we wake up to the sobering and alarming news around the latest effects of COVID-19, and that we certainly are in the middle of an emergency that threatens all aspects of our society, not just in the United States, but across the globe. Just by way of a short introduction and to expand on what the Roundtable on Health Equity does. It was established roughly 10 years ago and exists to surface critical questions around health equity and health disparities that confront our nation and communities. Thank you to the many sponsors who support this work. We could not get this work without foundation, corporate, government sponsors. We normally do this by convening in various locations across the country, bring forward experts and community voices to highlight a particular issue or insight, but because of the shelter in place, we're conducting this part of our year's agenda on a series of webinars. So we do invite all of you to follow our convenings throughout the year, as well as past workshops that we've had around health equity and health disparities. Also want to invite you very specifically, if you can provide your ideas about additional topics this roundtable should address with regards to COVID-19 in future webinars. We certainly are planning in a few more over the course of the next few months. So please put your suggestions, I think on the chat box or perhaps the Q&A box, but in any case, I think Kat had some information about how to get that to us. Given the extraordinary circumstances that the COVID-19 pandemic has brought, we felt it was urgent to organize a series of webinars around COVID-19 equity, as Kat had mentioned. Most importantly, thank you to all of you who have joined us today to highlight the importance of these issues. But first, let me again acknowledge the devastating toll the pandemic is taking on all of us. I speak on behalf of the Roundtable. We all hold in our thoughts those that have experienced illness, loss, death, suffering. We salute our essential workers, our essential frontline workers in our healthcare system who are confronting this trauma every day of caring for people who are acutely ill because of COVID-19. And now we also know that there may be long-lasting sequelae of people who've been infected by COVID-19 and even survive a hospitalization. We are having this discussion today because contact tracing can be seen as an important tool in slowing the spread of COVID-19. However, contact tracing must be conducted in a way that's appropriate to those communities experiencing the greatest burden of COVID-19. And as Kat mentioned, this is largely felt on the shoulders of communities of color, poor communities, and those that have been marginalized. We must take into account the distress that some communities have in healthcare systems and providers in the public health system, and the lack of individual and community resources to isolate or quarantine. So these are some of the things that we want to cover. Can we have the next slide on our objectives? Just so that everybody knows what we will be covering today, let me just go through these briefly. We want to provide a brief overview of contact tracing. We want to discuss contact tracing strategies that promote health equity in public health agencies in highly diverse counties and communities. We want to describe the contact tracing challenges in the Latinx community, including trust, residents without documentation, language barriers, and potential solutions to mitigate these challenges. And then we also want to learn about contact tracing challenges in one of the most highly impacted communities, Native American, American Indian communities that have seen an alarming number and rate of cases of COVID-19. The next slide is just a list of our planning members who put this webinar together. Rather than introduce each one individually, you can see their names. The planning committee included Mario De La Rosa, Rachel Fabi, Kevin Ahmad Jenkins, Melissa Simon, Reggie Tucker Seeley, and yours truly, and we'll all have some part to do with this webinar today in terms of asking our panelists some questions. So our first panelist, and please can we go back to Dr. Tony Aitan's slide, is Dr. Tony Aitan. He is the Senior Vice President of Healthy Communities at the California Endowment, a prominent philanthropic organization based in California. Prior to joining the endowment, Dr. Aitan served as both the Director and County Health Officer for the Alameda County Public Health Department. Dr. Aitan's career also includes past service as staff attorney and health policy analyst for the West Coast Regional Office of Consumers Union, the publisher of Consumer Reports magazine. And I just want to remind everybody in the audience, there will be time for questions from the audience. Please submit your questions in the Q&A box that appears on the bottom of your screen, and we'll certainly curate those questions and bring them up at the part during the part of the webinar that's devoted to Q&A. With that, I'm going to begin with Dr. Aitan. So Tony, I want to really thank you for taking time from your very precious and compressed day. I'm sure that every day brings a number of different challenges, not only for the California Endowment, but for our public health leaders, and that you're in the middle of it. But I do know too that in your work as one of the leading county health directors in the country, when you were leading Alameda County, that you were very much in tune with issues around following up on conditions and diseases that were affecting vulnerable communities. So with that in mind, can you just give us a sense, so we all have the same kind of footnotes about how you would describe contact tracing, what it really is meant to do, and then within the context of COVID-19?
Yes, good morning, Winston, and everybody. I see there are like almost 500 people on this webinar, so great. I just want to appreciate Winston's leadership, in this roundtable and his commitment to health equity, and Kat's great stewardship of this work. It's really been a pleasure to sort of watch both the process and the products over the years. I think I'll start off by just saying that the goal of contact tracing. I mean, we're in a deep amount of trouble here in the United States right now, and we have relatively few tools at our disposal to help protect our communities and the public. And contact tracing is one of those key tools. And to the extent that we have limited tools, we have to optimize the use of these tools. The goal of this tool, in conjunction with other tools like masks and social distancing and the like, is really to interrupt the cycle of transmission. And fundamentally, we have to keep that in our minds when we're either running a public health department or trying to communicate to the community about what the goal is. If we can isolate people with the virus from other people who don't have the virus, then we can slow or stop the transmission of the virus. So there are 5 key things that you have to do in contact tracing. One is you have to identify people who come into contact with a case, somebody who's tested positive for COVID-19. And the goal there, again, is that the fundamental step in the transmission of the virus is one infected person coming into contact and infecting an uninfected person who then becomes infected. So the first goal is to identify the contacts. The second goal is to notify those contacts of their potential exposure and let them know that they've been in contact in a way that suggests that they have a risk of having acquired that virus from somebody who was positive. The third step is to refer that contact for testing so we can document whether or not that person has in fact become positive and no longer just a contact, is now a case. And then the fourth step with a contact is that you want to actually monitor them to see if they become symptomatic. They may need health care, they may need other kinds of supports. And then finally, the fifth step is to connect, and this is particularly relevant for many of our communities of color who are socially socially the victims of essentially policy that has made them vulnerable. And so we want to connect them with services, and that may be food. It may be access to things like housing and shelter, safe shelters, safe places to either quarantine or isolate if they do become, in fact, infected. So those are the 5 steps. Identify the contacts, notify those contacts of the potential exposure, refer them for testing, monitor them for symptoms, and then connecting them with key services. And of course, there are huge issues that come up, particularly with vulnerable populations, with respect to the ethics of this work, building trust in communities that may be undocumented, that may be formerly incarcerated, that may be LGBTQ, that may be homeless. There are a whole host of ways in which people will not necessarily appreciate the outreach from a government agency to find out information about them and their movements. And of course, there's oftentimes very complicated logistics. People live complicated lives, and we're asking people to essentially disrupt those lives, for the purpose of protecting the larger community. So those are the 5 key issues, but very complicated, as I'm sure many of our panelists will talk about.
Yeah, thanks, Tony, for that great thumbnail sketch of what the basic foundations of contact tracing are. Now, I know that you've are playing a real key role in terms of bringing together county health officers and individuals that are responsible for putting together the contact tracing strategy in California. California has 58 counties and probably a lot more communities within those counties. Can you kind of discuss kind of the challenges that the communities and counties have in terms of putting this huge effort together, including issues around identifying the workforce, training the workforce, and coordination of how to allocate resources, particularly from a view of how we keep our eye on health equity?
Well, as we all know, because it's been very public, nationally, we've been struggling with testing. And testing and contact tracing go arm in arm, because you've got to be able to test to know who's positive, and then you've got to use those positives to track their contact. And so testing has been a problem, both the insufficiency of testing and now with the volume of cases, the turnaround in terms of getting results, in some cases in California and elsewhere in the country, has been 4, 5, 6, 7, even 10 days in some instances, which is really quite useless when it comes to using that information to try to get ahead of the epidemic and track its leading edge. So those are some of the real concerns. What we're doing in California, as a result of a request from the governor, is that we're helping put together, and I should start by saying that one of the core principles of this work is to try to match the demographics of the contact tracing workforce to the demographics of the epidemic. And I'm sure some of our other panelists will talk about that. But the demographics of this particular epidemic are really impacting people who are oftentimes vulnerable in multiple ways. Economically, socially, they have health disparities, they have linguistic issues, they may have immigration issues, they may have issues with law enforcement. So there are a whole host of challenges in trying to stand up a workforce that actually can build the kind of trust, and that's what's key, trust with the communities that are most impacted, particularly looking at where the epidemic is going, not so much where the epidemic has been. So we're working with a network of workforce CBOs in California to help them do outreach and recruit this new workforce, and then tying this new workforce into our local health departments. There are 61 jurisdictions in California, 58 counties, 3 cities. And the goal is to have those local health departments have access to a highly diverse, both culturally and linguistically, workforce for doing contact tracing, so that they can optimize that issue of trust in their communities and be able to actually reach out to people in a way that doesn't offend them, frighten them, or turn them off. This is a big goal. We're trying to recruit 20,000 people in California, but 20,000 of the right people. And we also see this as an economic development opportunity for many of these communities that have been impacted. These can be very good jobs, $25 to $30 an hour with benefits. And our goal is to help them tap into a workforce pathway and a career trajectory that actually offers a career ladder within either health departments or healthcare institutions.
It's a mighty task, but I think the essential components are actually quite reassuring that the folks that are putting this together have those perspectives in mind. The last question I have for you, Tony, is despite the fact that you've been telling all this to me, you're not a public official. You're part of a philanthropic organization. And I wondered if you could talk a little bit about how we're associating or figuring out the contact tracing strategy in terms of bringing together public and private partnerships? How's that really work, and is it workable?
Yeah, well, the first thing is, once a public health officer, always a public health officer. So, you know, I may no longer be an active public health officer, but it's in my blood. The second issue is that in California, as with other states that are experiencing the resurgence of the virus, it is all hands on deck. And so the philanthropic community has come together. We've brought together 10 large foundations in California who've pooled their resources and offered these resources to the state to help complement the state's resources, and quite frankly, Kaiser Permanente, who's been very active in this as well. It's an all hands on deck situation. We all recognize that the state is doing as much as it can. People are exhausted. They're running at full speed for months, and philanthropy can do its part. And our particular role in this is to complement and help facilitate the efficacy of the state's effort. And that means our focus is really on getting this contact tracing workforce right, making sure that we have a culturally and linguistically competent workforce to match the demographics of the epidemic. Because the government, quite frankly, will do this fast. They'll do this as fast as they can using their existing mechanisms. And you know, diversity and cultural competency probably won't be the first thing on their agenda. But for philanthropy, we have the ability to essentially take a longer view and recognize the sort of the win-win aspects of getting a highly culturally and linguistically competent workforce to manage the contact tracing aspects of this epidemic. So that's what we're doing. We think our model is a good model for California, and we hope it will work.
Great stuff, Tony. Thank you. And we'll return to Tony later when we have a broader Q&A discussion. Now I do want to introduce Dr. Gira Ravello. Gira is a research associate professor with the Center for Research on U.S. Latinos, HIV/AIDS, and drug use at Florida International University. During the past 10 years, her research has focused on the socioeconomic influences of health disparities among vulnerable Latinx subgroups such as agricultural farm workers, low-income, urban, and sexual gender minority communities of the Miami-Dade County, Florida region. Much of her research work involves collaborative efforts with community agencies and leaders and stakeholders. Dr. Ravello is a graduate of the University of New Mexico in Albuquerque. She is a former United States Air Force member and has a master's and a PhD in social work from Florida International University. So with that, I want to invite Dr. Mario De La Rosa to ask some questions of Dr. Ravello.
Thank you, Winston. Well, thank you so much, Dr. Ravello, for spending some time with us today on this very important topic. And I know that we're here in Miami. As you know, I'm a professor in the School of Social Work at the Robert Stemple College of Public Health and Social Work at Florida International University in Miami, Florida. So as I was saying, thank you so much for being here with us. You know, we're here in Miami, which is one of the epicenters of the COVID-19 epidemic in these days. So you know, I would just like to ask you, you know, to share some of your ideas and experiences or lessons learned that will lead us to develop a more effective contact tracing program here in Miami-Dade County with particularly with Latino communities. So I'm looking forward to your discussion on that.
Right, thank you. First I'd like to thank you, Dr. De La Rosa, for suggesting that I be on this panel, and of course my thanks to Dr. Anderson for having me on today. First I'd like to paint a broader picture of a little bit of what's going on here in Florida. We're actually now being thought of as the new epicenter and the new hotspot for COVID, South Florida in particular. In fact, where we are here in Miami-Dade County, which is the southern tip of Florida, it's we've been by far the most effective, with over 113,000 cases. Last time I checked last night, it was over 113,000. Our neighboring county, Broward, which actually has the highest number of cases, it's not even half of what Miami-Dade County has. And they're actually the second highest. So we're very much at the very epicenter of it all right now, unfortunately. And over 69% of our county's population identifies as Latinx. And as we know, these Latinos are part of the vulnerable populations that are being hit, the hardest. Now, in terms of what I've learned in the years that, like Dr. Wong had mentioned, I've spent over 10 years working with this community, and what I've learned in working with them is that in order for any program to be effective, including contact tracing, to be effective among the most vulnerable here, even under the best of circumstances, is that you have to address that very substantiated mistrust that has already been a topic here in this webinar, and the fears and the culture. Those things have to be addressed in order for any program to be effective. Obviously, like Tony had mentioned, contact tracing is married to testing, right? So like you mentioned, the first step would be to actually identify the contact. And without trust, you're not even going to get them to test, quite honestly, much less give you the names and phone numbers of their other undocumented friends, their relatives or their coworkers, right? They're not going to give you the information of where they work, where they may likely be getting paid under the table. I mean, a lot of them will only get tested in sites that don't require identification. And some of those get set up every so often, and they advertise among each other. They send messages to each other. They go through community workers to let everyone know that there's going to be a testing site that isn't going to require test and identification. And those are the ones that they're more likely to go to. And they do go out and screen them first. And they spread the word out to the community. So this is why trust is so important in this community. Without it, it's hard to get them to test, much less participate with contact tracing, right? In fact, for immigrants, especially undocumented, the term alone is threatening. This contact tracing. To anyone that's trying to stay low, the term itself is threatening. So, why the mistrust? Well, it's fear. Basically, it's mostly rooted in fear, and the fear of being discovered, their undocumented status, or a relative that they might be living with that's undocumented, or a close friend, because many of them, live in overcrowded households. Just the idea of bringing any kind of government agency or personnel into their lives is very scary for them. The fear, and this actually comes directly from a community leader that I spoke to that's very active in undocumented Latino community. She said to me, the fear of being deported is greater than anything else, than any other fear that they could be facing. They'll endure living on the streets. They'll endure working double shifts for half pay. They'll endure abuse, violence, sex work. They'll endure almost anything to not call attention on themselves, right, over the fear of being deported. So getting COVID almost becomes the least of their problems. The consequences of it, however, the economic and personal impact of COVID is for them much worse than the thought of getting it itself, right? So, I mean, now they do have people, community leaders and institutions that they do trust. They'll trust what friends and relatives tell them, or the lady who does their hair. They use text messaging, like I mentioned earlier. They have group texting that they keep each other informed with of like imminent risks. to the community. So these are the people and the things that we tap into when we work with the communities, right? So, but that requires having a long-standing relationship with those leaders in those institutes. Okay, so for a program like contact tracing that can make them feel like they're about to get an ankle brace, so to speak, the trusted community leaders have to be a part of it. They have to be on the front lines where they're visible to the community so they can feel safe.
Dr. Revelo, thank you for your very comprehensive discussion on contact tracing. So you're saying that there are barriers, but there's also some strengths in the community that can really help in really developing a good contact tracing program, and which you should be aware of those. And can you kind of expand upon a little bit more on the strengths? I know there are many barriers, but can you talk a little bit more about and maybe give us 1 or 2 examples?
Sure. Well, one of the strengths, I think, is their sense of community. Latinos are collective culture, so they maintain that collective accountability, something that's been studied extensively, within the context of the family. That it's what we call familismo. So that is a strength. Their own culture can be a strength. Their dedication to family. So from a program planning type of perspective, appealing to their sense of collective culture and collectiveness and family and community, which underscores, again, the importance of trust, that in itself can be a strength because they worry about their families. So when appealing to them and trying to go the route of, how is this beneficial to me? Why would I do this? So, going through their appealing to their sense of community is definitely a strength. And the community leaders themselves are very much dedicated to the communities and to the community members. And that in itself is a strength. And you would be amazed at how dedicated they are and their willingness to give to the community and to help the community.
Thank you, Dr. Ravelo, for your very comprehensive discussion on contact tracing in the Latino community. Wisdom?
Yes, and thank you, Dr. Ravelo, again. And those of you in the audience who mentioned that when I turn my head, you don't hear me so well, thank you, well noted, and I'll try to look face forward most of the time here. Our next speaker is Dr. Amy Dixit. She's an epidemiologist and a student and the student development director at the Albuquerque Area Southwest Tribal Epidemiology Center. She earned her PhD in infectious disease epidemiology, as well as her MPH in epidemiology from the University of California, Irvine. Dr. Dixit has been with the AASTEC since early 2017. And for our series of questions for Dr. Dixit, I'm going to invite Rachel Fabi from our roundtable to pose those questions. So Rachel.
Thanks, Winston. So I'm Rachel Fabi. I'm an assistant professor of bioethics and humanities at SUNY Upstate Medical University. And I'm also serving as the National Academy of Medicine's Greenwell Fellow in Bioethics. And I'm so happy to have Dr. Dixit here today. So our first question for you, Dr. Dixit. Many Native Americans live in multi-generational homes, making it difficult to isolate or quarantine from family members. How do you address this, and how do you address privacy concerns in multi-generational homes?
Thanks for the question, Rachel, and thanks for the introduction, Dr. Wong. So I work at an organization, the Albuquerque Area Southwest Tribal Epidemiology Center, also known as Aztec, and we're one of 12 tribal epidemiology centers across the country. And in our area, which is the Albuquerque Indian Health Service area, we of course do see a lot of what you're referring to with multi-generational homes, many family members living in one house. And generally in the tribal communities that we serve, in that culture or those cultures, that's a resiliency factor. having having your grandparents, your great-grandparents living in the same home with you, passing down cultural traditions, languages, that is seen as a strength. However, during this pandemic, the close-knit family structure and the high occupancy in these dwellings has led to higher secondary attack rates within the family members. But the thing is that both the tribes and the state government, the New Mexico state government, has recognized this early on and has worked together to establish several alternate care sites around the state to provide family members or close contacts with a safe space to either recover from their infection or to safely quarantine away from family members who are isolating and recovering at home. Several tribes have also repurposed local facilities or provided mobile dwellings such as repurposed trailers or for family members to safely isolate while remaining near family and friends and remaining on tribal lands. The privacy concern that you brought up is very true. What we are doing is we're using cell phones to do contact tracing. We're of course not doing this in person because of a myriad factors, but doing contact tracing and monitoring over the phone does allow for a little bit of additional privacy because someone can take the phone call away from their family. But what we are finding in a lot of our communities, by the time we start the investigation, by the time we learn of a case and we start the investigation, we call the case, we find out that the case has already told their close contacts about their status because of consideration and worry for their family and friends. And we also offer an option to enroll the cases and contacts in the text illness messaging system that's hosted by the CDC so that we can conduct our monitoring activities about their symptoms or, test results or whatever over text instead of calling every day. And that affords a little bit more privacy as well.
Thanks so much. Our next question is also about barriers that Native American families may be experiencing. We know that many tribal members may live on remote reservation land. So what are the challenges involved with contact tracing in remote locations, and how are resources brought to homes in remote locations?
Yeah, certainly, when we think of remote locations, one thing that certainly will come about is spotty cell coverage. And as I mentioned, we are doing contact tracing efforts over cell phones, or if we can get them, landlines. But spotty cell phone coverage and a general sort of wariness of unknown phone numbers, as we're all want to do nowadays with telemarketers. General wariness of these answering unknown phone numbers does present a bit of a challenge. So what we do is we try our best to make sure we're leaving enough information about ourselves in voicemails or some sort of introductory message to encourage people to call us back when they have reception or once they've heard the message and know that we are legitimate. We also have developed, very strong relationships with the communities that we serve. And so we try to utilize our networks within those communities to get the best contact information possible with for our cases and contacts. And we work with the tribal program staff. So whether it's community health workers or public health nurses, senior center staff, tribal administration, we work with them to make sure that people are aware that we're going to be reaching out to them, should they test positive. Or should they end up being a close contact with someone who tested positive. And we leverage our network that way to make sure that there's some familiarity with our name and presence. And then of course, with regards to resources too, several communities that we're serving have established either incident command systems or some form of emergency response system that works together across the departments within the tribal community, whether it's housing or natural resources, whatever, coming together to create food distribution systems and also to distribute supplies like cleaning supplies or masks, to set up laundry services. And so when we're invited, we participate in within the emergency response system or incident command systems. And then when we're communicating with our contacts, if they let us know of any needs they have, we try to communicate that directly to the established structure so that their needs can be met effectively. in terms of, resources like educational materials, new guidance. Aztec is also, is pretty on the ball with creating new educational fact sheets or visual graphics intended to get the right message across about wearing masks or, staying home for the protection of your community. And so we try to mail those directly to the tribes so that they can include them when they're doing their distributions or have them readily available for their community members to access. And of course, we're on social media, much like everybody else. So when, when that's available, people are welcome to join our Facebook or Instagram pages to look at what the messaging that we're putting out is.
Thank you. That's so helpful for understanding the coordination, especially about the distribution of resources. And it's a good segue for our third question for you, which is also about the sort of governmental coordination. Who is responsible for coordinating tribal contact tracing efforts with state and local government contact tracing efforts? And is that challenging?
So again, Aztec is a tribal serving organization, and so we don't impose ourselves on any community that isn't inviting us to participate within, within their community for contact tracing efforts. But this really is a very highly coordinated endeavor between Aztec, the IHS or Indian Health Service Albuquerque area office, tribal leadership for all the tribal communities that would like assistance, tribal clinics, whether they are supported by the Indian Health Service or whether they are self-directed, and as well as, of course, the State Department of Health. And so we all work together to coordinate these tracing efforts. And, we certainly work to ensure a good working relationship with all entities. And, I've heard the other panelists mention trust and good communication, and that's really critical to mitigate some of the challenges that pop up, because sometimes decisions do need to be made quickly. And so it works really well when all parties are engaged. We, of course, work really hard to gain and retain the trust of our tribal partners, and we're committed to honoring their wishes in all decisions, because tribes are sovereign nations and tribal leadership has the ultimate say as to who's going to lead the case investigations and contact tracing efforts in their own communities.
Thanks so much. So I think we're going to now turn to questions for all of the panelists together. So if we could get Dr. Ravello and Dr. Aiton back as well. Our first question is, how can contact tracing strategies be developed to address issues around systemic racism?
I'll take a crack at that one. That's a very heavy question. So I don't think contact tracing itself can undo systemic racism, but I do think that part of the strategy, and this is what we've tried to do in California, is be very, very, very intentional about the contact tracing workforce and to try to recruit from the communities that are most impacted by the virus. And the communities that are most impacted by the virus are those that are most impacted by structural racism. And if we had more time to talk about this, we could talk about policy violence, which is the absence of policy in the face of abject need. And that's what we're seeing in many of our communities. They are the product of policy violence because they, lack health care, they lack living wage jobs, they lack adequate housing, and the list goes on. That's the product of the failure of policy in the face of abject need. And that's a form of violence, and it's state-sanctioned violence. And so at a minimum, we can try to repair some of that injury by recruiting for these living wage jobs the people that are most impacted by that history of structural racism and policy violence.
I can add to that a little bit. I agree, with Tony. It is really about having the demographics of the contact tracing workforce represent the demographics of those who are impacted by this pandemic, by this disease. And some of what we're doing to work towards, alleviating some of that is trying to, obviously we're a tribal serving organization, so we have certainly some people who are able to speak some of the native languages who, that are spoken in our area. And so effective utilization of tribal languages is a critical tool in working to sort of develop functional contact tracing strategies within tribal communities. And then really importantly, adherence to Indigenous data sovereignty principles is also an important way to ensure that the data remains within the community and does not serve to perpetuate racial profiling and further stigmatization of the community. Respecting and recognizing that there are established systems of leadership and governance within tribal communities is critical, because not every tribal member is authorized to speak or act on behalf of their community, and it's important to involve tribal leadership in all of the decisions, respect their sovereignty, respect autonomy, and think about how those decisions are going to impact their community.
Dr. Ravello, do you want to speak to that question?
I did. Actually, my thought about that is if contact tracing could be merged with a screening strategy of a sort, where you're screening, these same people who are, clearly were at risk for being infected with COVID. If we could somehow combine it with a screening where you're screening for, say, other chronic conditions or issues of access to health, then, I mean, that would be, I believe, a good way to address some of the issues that are affecting those who are, many of those who are being affected.
Thanks so much. Our next question is going to come from Roundtable member Dr. Reggie Tucker-Seeley. Reggie?
Thank you, Rachel. As Rachel mentioned, my name is Reggie Tucker-Seeley. I'm a member of the Roundtable on the Promotion of Health Equity and also an assistant professor of gerontology at the Leonard Davis School of Gerontology at the University of Southern California. So my question is, are any of you using or working with organizations that are using technology-based contact tracing? And if so, are there specific issues related to specific technology use in communities of color?
I can start. We've tried to stay away from some aspects of technology for the reasons that there are big privacy concerns about tracking people's locations, as was discussed by some of the other panelists. But there are a couple of aspects of technology that are particularly useful to contact tracing. One of them is, when somebody is under quarantine, you want to actually check in with them fairly regularly, like daily. And that's very labor intensive for health departments. And so we've been working with some of our county health departments to actually try to find them software and applications that will allow them to essentially have two-way communications that are automated with folks that are under quarantine. So folks can, when they get up in the morning, basically answer some standard questions, submit those questions, and it'll populate a database and flag for the health department anybody who's starting to show symptoms, rather than having to affirmatively call everybody who's in quarantine every single day. But that's just one aspect of sort of highly efficient use of a limited resource that doesn't invade privacy in the way that asking people for their location records might do.
Dr. Dixit or Dr. Ravello?
Okay, I'm sorry, I was muted. I think that particularly the community that we're working with in the undocumented and farm working Latino community, many of them are just shy away from technology-based type of contact tracing. Again, back to the issue of being a community that tries to basically stay undetected. The last thing they want to do is be followed around on their phone. as they see it. Some of the things that go on in that community, a lot of them is misinformation that is born from some of these things. Like, you know, I've heard community leaders tell me that many of them feel, you know, they don't want to get tested because they feel that what they're doing when you go get tested is that they're implanting a chip inside of them to trace them around. Okay, so I mean, obviously misinformation that is a combination of testing and contact tracing and the use of technology, and you know, these stories come together and sort of these tales go around, and they get told, you know, via text message. They start telling each other. So it's not something that they would be very keen on doing. Right now, some of the agencies that we're working with are really actually struggling with keeping up with the contact tracing, and we're trying to work with them in helping them maybe with staffing and with technical issues.
Okay, great. Thanks, Dr. Ravello. Dr. Dixit?
Sure. So as I mentioned, we are using the CDC app, the text illness messaging system, giving people an opportunity to respond when they're under quarantine and they're defined as a close contact, not when they're a case, but giving people an opportunity to be monitored for symptoms using the text illness messaging system, or TIMS. And that brings its own challenges. I think a lot of people, especially older people, just prefer calls from us, and we tend to build relationships that way. So we enjoy that opportunity too.
Okay, great, thank you. So now I'll hand it over to Dr. Kevin Jenkins for our next set of questions.
Right, well, hello everyone. Thank you again. Thank you, Reggie, for passing it along. My name is Kevin Jenkins, and I'm a social epidemiologist, and I work over at the VA here in Philadelphia, Pennsylvania, as well as a lecturer at the University of Pennsylvania, specifically focused in health policy. So my question is regarding the many hats that contact tracers are suggested to wear at this point. Oftentimes, many people kind of think we need them as utility folks, as going in the community to be able to connect people to the social resources, as well as to inform about how to manage and deal with their symptoms, as well as how to handle the quarantine. So we just want to kind of understand, how do you feel that it's best to train and particularly support contact tracers so that they're able to also do the social component while also dealing with the public health way?
Well, that's, if it's okay, I'd like to go ahead and answer that first. We did have a project where we actually trained community leaders to become community health workers in linking community members to local resources and services. And we put them through the training, and we provided them with an application that listed all the local services and resources of the community. And you know, that's something that they really liked. They learned a lot. They learned to really be able to find the root of the problem, learn how to identify the real need, and they were also trained culturally. Now, these are people that already came with case management type of experience and case management type of skills. So being able to marry that with an application that just, or something that gave them all the resources at their fingertip, worked out really well. For contact tracers, you know, not everyone may want or need these social services or want to have case management. So, I mean, there's always, and like you mentioned first, Kevin, it seems like they might feel like they're getting overwhelmed if they're being asked to do all these things. And, you know, there's always just asking if the the person would like to receive these services, and then passing it on to someone like case management, community health worker type of person that can do these things, that can link them to community services.
Thank you for that. Dr. Dixon, I'm going to jump the order and try that. How about that?
Sounds good. Similarly, we also, for the communities that we are assisting with contact tracing efforts, we talk to administration, we talk to leadership, we develop resource lists for each community. And what we do is we assign certain contact tracers to individual communities so that then they are focused on the needs and the services offered by that community. And so as part of our contact tracing script, we make sure we hand them this resource list and let them know of what's available in the community. And, for instance, some of the communities have their own behavioral health programs and they're ready to assist with coping mechanisms in a culturally competent manner. And we want to make sure we inform our contacts and cases of that resources at every opportunity. So if there is a certain need that we don't have a response to, we make sure we share that with incident command or leadership or emergency management, whatever, so that that need can be addressed in whatever way possible. But yeah, I mean, we understand that our contact tracers do a lot more than just, monitoring for symptoms and getting people enrolled. They are there to provide an ear, a shoulder to cry on sometimes, an ear for support. And so we like them to know everything that the community is ready to offer their clients when they make that call.
Thank you for that. Dr. Aitan?
Yeah, I don't have much to add to that. The only thing I would suggest is that in making referrals, that warm handoffs are better than cold handoffs. In other words, facilitating sort of a direct transfer of somebody to another human being who can provide the resource. And California, we're very lucky. We have a robust network of federally qualified health centers that have high levels of trust with communities that are socially vulnerable. And, many of them are actually doing contact tracing themselves of the patients that they see. But when we make a referral, we try to make sure that that referral isn't just a list, but instead it's a very specific, stay on the phone. I'm going to patch in somebody from La Clínica de la Raza to talk to you about, some resource that you need or some other community-based organization. And for a vulnerable community, they need warm handoffs. Cold handoffs, often they fall through those cracks.
Thank you so much for that. So for our last roundtable related question, the big thing we always have to do is find the best way to summarize, right? So we want to try to ensure that our attendees have at least 2 points from each of you that you think are critical takeaways from today's conversation. So with that, I would like to try to start with you, Dr. Aitan, to round that out.
My first big takeaway is to do everything humanly possible to match the demographics of the contact tracing workforce with the demographics of the epidemic itself, particularly the leading edge of the epidemic. The goal of contact tracing is to interrupt the cycle of transmission, and you do that through the work of essentially building trust in the communities that are most vulnerable. So I think that is the most critical thing. And secondly is that contact tracing is kind of an old school tool, but it works. And if you invest in the right kind of people to do that contact tracing, you will see the impacts on your epidemic locally or in the region in which you're operating. So believe in contact tracing would be my second point.
Thank you. Dr. Ravello?
Yes, I'd have to echo on the trust, absolutely. I think by far that's the most important thing with these communities, having that trust, and also in the use of the community leaders that have the trust of the community. And of course, keeping in mind the culture of the target population and the strengths and the barriers of the culture, that be it language or be it the collectiveness that Latinos have. So I would have to say that the culture, keeping that in mind, and also the very important issue of trust.
Thank you. Thank you, Dr. Dixit.
Sure, just like Dr. Ravello and Dr. Aitan have shared, you know, working with tribal communities, relationships that are built on trust and solid communication are going to be much more fruitful than anything else. So when we're working with the tribes, our Department of Health, IHS, tribal health programs, transparency and a respect for Indigenous sovereignty is really, really critical. That's my number one thing. And then secondly, I would say that please keep in mind that there should be mental health considerations for both sides of that phone call. The contact tracers absorb a lot of what they're sharing on the phone call, what they're hearing from their contacts. They're usually making these phone calls for 14 or more days straight. And, that can be quite impactful. And then of course, the person who is enduring the impacts of the disease in their family, in their community, also deserves considerations for, how to cope with what's going on and, what other resources could we be providing them to support their mental health. So mental health on both sides of the line is important as well.
What amazing points. Wow. Thank you all for that. We have enough time now to answer some questions. So I want to turn it back over to our roundtable director, Dr. Kat Anderson, so we can get some questions from the audience. Thank you again, panelists, and thank you again for the opportunity.
Okay, the first question I want to ask is for Dr. Dixit. Could Dr. Dixit say more about the community emergency response centers? Who sets them up? Who joins them? Where do they get resources?
Sure. So, I'm using this kind of as a catch-all term, but generally there is either an incident command system or some sort of emergency response system that the community comes together. They put together their first responders, tribal leadership, directors from their various departments. And I'm not 100% certain on the funding. I think there is some available through FEMA. FEMA certainly has courses on incident command and emergency response systems that I think the tribes encourage their upper management and all to take. But that's really where the incident command system structure is modeled on. And so I work with a couple of different tribes specifically, and I know that in those tribes, the incident command structure is made up of directors from health and wellness, from tribal leadership, from tribal administration, natural resources. In another, the school board's really involved. And so it's really just the leaders within the community, not just the elected or appointed leaders, but also from within the departments coming together to think about, okay, how can we work to ensure good collaborative efforts to make sure that resources are directed to the community members as they're needed, and where can we apply for more funding, say? How do we make sure we get the resources that we need? Hopefully that answered your question.
Thank you. Okay, this question is for all of you. Often a clinician is the first person someone sees when being tested or diagnosed for COVID-19. What advice do you have for clinicians that helps them encourage rather than discourage cooperation with contact tracers?
That's a great question. My spouse is a clinician who does contact tracing in San Francisco. And I think one of the things that she has recognized is that if you can lay out to the patient more information about what's likely to happen when they get their positive test result, and collect as much information up front. You know, one of the challenges we've had in California and across the country is looking at the racial demographics of positive tests because so much of the information is missing. So I would say both collecting as much information up front as possible, including the nature of employment of the patient, if possible, and then explaining to them what's likely to happen when they get a positive test so that they're prepared, you know, to think about their contacts and all that when the contact tracer gets in touch with them.
Okay, thank you, Dr. Eitan. Dr. Ravello, this question is for you from Bibiana. I am in Columbus, Ohio. We are having a lot of trouble doing contact tracing with Latino folks due to the language that the local health department is using in their letter. They are mentioning something about legal action. I am wondering what your recommendations are.
I'm sorry, mentioning something about legal action?
Yeah.
Because of the language that's being used?
She says they're having trouble doing contact tracing due to the language that the local health department is using.
Okay. Well, the only thing I imagine what she means by that is that it's either not in Spanish or it's in a very, it's a upper level Spanish that when you're talking about lower income, lower educated Latinos, the Spanish needs to be obviously at the level of your audience. And also you have different countries of origin that have their different types of dialects, so to speak. They have different words for the same thing. So you have to be aware of who the majority of the Latinos are. So if you're speaking to, say, the majority maybe Mexican versus the majority being Venezuelan, you have to, or Colombian, you have to be aware of that. You have to be aware of what is their country of origin, at least for the majority. And the language needs to be appropriate to that country. I mean, there are little things, aside from also the level of the Spanish, there's also, you know, different words, different dialect. So again, that's just a matter of being aware of the cultural awareness of that particular country.
Thank you.
Kat, I think that question may have been about legal language in the sense of health officer's order, which typically has the statutes that its authority is under, and you know, kind of a little bit of an implied threat about if you don't comply. And so there's an art to writing these letters in a way that doesn't necessarily spook people. And I think folks that may have, you know, mixed status families, immigration issues, don't want letters from the government saying that legal action may be taken against you. So if that's what the questioner was asking, you can write a letter that leaves all that stuff out and is just informative and is sort of embracing the relationship between the you know, the potential contact tracer and the patient. And many health departments are aware of that, so they don't put enforcement language in these letters.
Thank you, Dr. Eitan. Okay, last question. Are Black people disproportionately affected by COVID-19? And I'd like to know why they're not highlighted in this webinar like the other populations. I worry this erasure also sends a message that we're not focusing truly on equity-based data.
So, Kat, would you like me to address that as the chairperson of the Roundtable on Health Equity?
Absolutely. Thank you.
For sure, the evidence is clear that the Black and African American community are suffering 2 to 3 times of COVID-19 relative to the proportionality in their communities. I also would mention too that Pacific Islanders and Native Hawaiians are also in many communities, Utah, Hawaii, California, are seeing mortality rates that are about 3 times higher than their proportion in the general community. So it is very clear that there is all the features of racism that impacts the African American, Black community, the Asian Pacific Islander community relative to COVID-19. I would suggest to the participant that they look at our first webinar with regards to data and how we understand the impact of COVID-19, because we had a number of speakers who really spoke very eloquently about the issues around historic racism, how the Black community has been really, this does not begin with COVID-19. It begins with the legacy of how public health has failed communities of color. So we fully recognize that, and we wanted today to focus on issues of contact tracing as a particular aspect. And we did want to relate to all communities, not just ethnic racial communities, but we didn't even touch on issues around gender, marginalized communities, trans communities that are probably not getting the full impact of what we need to do in terms of really public health intervention, to Dr. Aitan's point. But I'll just leave it to any of our panelists if they want to speak to any aspect relevant specifically to the African American community and contact tracing right now.
Yeah, go ahead.
This is Melissa. Go ahead. No, please, Dr. Aitan, fine. This is Melissa Simon from the Roundtable. Please go for it.
Well, just to say that, you know, we are very much engaged. As I mentioned, our mantra is match the demographics of the contact tracing workforce with the demographics of the epidemic. And in California, the demographics of the epidemic show the exact disproportionality that Dr. Wong was talking about. Latinos, African Americans, Pacific Islanders, all disproportionate deaths. Latinos, disproportionate cases in California, and to some extent Pacific Islanders. African Americans are actually not disproportionate in California. This is not the case in other parts of the country, but in California, they're not disproportionate in terms of the incidence of cases, just in the proportion of deaths. But nevertheless, we are focusing, particularly in communities like Oakland and Los Angeles and in the Central Valley and the Inland Empire, on reaching out to African Americans serving community-based organizations to recruit contact tracers into what we consider to be living wage jobs in local government, with career ladders into you know, other jobs over time. And we're focusing on African American communities, Latino communities, and Pacific Islander communities, and specifically targeting community-based organizations that both reach those populations, have trusted relationships, serve those populations for both contact tracing and for you know, community-based services for folks that need services when they're in quarantine or isolation.
Thanks, Dr. Aitan. This has been an extraordinary webinar. Thank you to our panelists who are really experts in their field, as well as being champions and really fighting for our communities. Certainly, I want to thank the NASM staff for putting this webinar together. This webinar was recorded and will be available, I believe, for 75 days afterwards. So please, if you have friends or colleagues that would like to see this webinar in entirety, it's available online. I think we have that link that was available made earlier. We encourage all of our attendees today to give us suggestions about topics for future webinars, and please put your suggestions in the Q&A box. Finally, I want to thank everybody at the National Academy for putting this webinar together, and be safe, stay strong, and keep the fight going. Thank you, everybody. And with that, we'll end.
Thank you.